consider another meta-analysis on the SGLT2 inhibitors. This meta-analysis we carried out together with Darren McGuire, a colleague, a cardiologist from Dallas. And here you look at this table at the combined results of all the trials which we know have been published. EMPA-REG outcome with empagliflozin, Canvas program with CANA, and you can see that the dots are below the unity line, clearly indicating that drugs such as empagliflozin, canagliflozin have done a very significant reduction of major adverse cardiovascular events. This is not the case for DECLARE with dapagliflozin and VERTIS-CV with ertogliflozin, because as you can see, these are the hazard ratio is crossing the unity line, so not such a significant effect. But also in this meta-analysis, we stratify our patients according to the presence of the atherosclerotic cardiovascular disease status. And you can see that in patient with atherosclerotic cardiovascular disease, this upper panel of the lower table, you have a cumulative reduction with an hazard ratio of 0.89, so 11% relative risk reduction in patients with established cardiovascular disease. On the lower side, you have patients without established cardiovascular disease, and you can see that it's more heterogeneous, the results here. Only trial like Credence with canagliflozin show a significant effect in reducing MACE. And I would like to remind you that patients in Credence were patients with diabetes and chronic kidney disease. Again, pointing out to the fact that nephropathy is an equivalent of cardiovascular disease, because when you have nephropathy, then you get a real protective significant effect by implementing a treatment with SGLT2 inhibitor. Now, that's the reason why we ended up to give for both classes of glucose-lowering drugs, GLP-1 and SGLT2 inhibitors, very strong class 1 level of evidence A type of recommendation. But then, if the case is, as we know, as you endocrinologists, diabetologists teach us cardiologists, often is not enough one glucose-lowering treatment to achieve a good glucose control. So once we have given the first-line treatment drugs, if we have to combine other glucose-lowering medication because we need additional glucose control, here we have the glucose-lowering agents which suggest the cardiovascular benefit. And for metformin, which has been traditionally a first-line drugs until not too long ago, but this position of metformin has been bypassed by the two classes I just presented to you, but we elevated metformin in this last edition of the guidelines to a class 2A recommendation. So should be recommended if additional glucose control are needed. And then we come to pioglitazone. Pioglitazone for us cardiologists is a rather controversial, has raised a lot of debates, and I will get back later on this. But pioglitazone received a class 2B recommendation, so it means that may be considered if additional glucose control is needed. And now let's take into consideration the issue of metformin. Here I like meta-analysis, so another meta-analysis here. Here we have a meta-analysis of all randomized placebo-controlled trials with meta-analysis, with metformin. And you can see, if we look at cardiovascular death, the upper panel, you see that we have a point estimate approaching the unity line, and the confidence interval is crossing it, which means no proven cardiovascular efficacy. We have it is a very small number, but a confidence interval of 1.16 means that it's crossing it, so we do not have cardiovascular benefit, but importantly we can see that by this upper confidence of interval that metformin is safe. It's a safe drug to be used in our patient. And the same holds true for the myocardial infarction endpoint. When we talk about metformin, I think it is very important to mention that we have the extended release formulation of metformin, and patients are more satisfied, and if they are satisfied, we were talking about compliance before, they are more adherent to the treatment, and they stay on the treatment with metformin, because we know that metformin may give some gastrointestinal side effects. And as you can see here, based on diabetes treatment satisfaction questionnaire, the patient, 83% of the patient prefer the extended formulation of metformin as compared to the immediate release of the drug, because they experience less gastrointestinal side effect. So the adherence to the treatment of metformin significantly increase by switching from the immediate release formulation to the extended release one. And as I say, less incidence of GI side effect, so an improved GI tolerability. Now, I was talking to you about pioglitazone, which got a 2B class recommendation, may be considered if additional glucose control is needed. Here we have a meta-analysis which is pulling together all the trials with pioglitazone, and I would like to remind to you that there is one trial which has created some debate, the proactive trial, because the proactive trial was showing that the secondary endpoint, MACE, was significantly reduced, but the primary composite endpoint did not reach statistical significance. And if you look at this meta-analysis, all the different endpoints which is taken into consideration by the author of this meta-analysis, so the 3-point MACE, MI alone, stroke alone, all a significant reduction. But the meta-analysis, as it was shown also in proactive trial, showed that there is a 32% increase in heart failure risk. And we know, as cardiologists, that pioglitazone may give an increased risk of heart failure. And indeed, these are the recommendations. For metformin, there is a class 2A, as I say. For pioglitazone, a 2B, because it may be considered in patients with diabetes and established atherosclerotic cardiovascular disease if these patients have no sign or symptom of heart failure, because then there is a contraindication to pioglitazone. Now, in the case we need additional glucose-lowering drugs on board, here you can see that on the lower part of this table, there are drugs like DPP-4 inhibitors, sulfonylureas, and other GLP-1 receptor agonists, which can be considered because they have proven cardiovascular benefit. And this is important to mention, because until not too long ago, until 2008, we didn't have any ideas about the safety of glucose-lowering medication. but from the FDA regulation, which was really reinforcing all the trialists to prove cardiovascular safety of any newer glucose-lowering drugs, now we can say with confidence that certain drugs, although they do not have a cardiovascular benefit, they are safe. And I think this is important. Now, if we consider treatment of patients with diabetes and heart failure, these are a recommendation of the newer guidelines to reduce heart failure-related outcomes in all patients with diabetes and heart failure, regardless of the heart failure phenotypes. We know that there is heart failure with preserved ejection fraction, heart failure with reduced ejection fraction, and then there is an intermediate form of heart failure, mid-range. Despite of all these phenotypes, the first-line class of glucose-lowering agents that has to be used in patients with type 2 diabetes and heart failure are the SGLT2 inhibitors. And this has to be given independent of glycated hemoglobin level, regardless of other concomitant glucose-lowering medication. And of course, if we consider patients with FREF, heart failure with reduced ejection fraction, we need to give SGLT2 inhibitors on top of medication like the ACE inhibitors, the beta blockers, the mineral receptor corticoid antagonist. So this is the fourth foundational pillar in the management of patients with heart failure. Before we had only 3 pillars, now we have added a fourth one because SGLT2 inhibitor has to be added as a first-line drug in this type of patients. And then, if we need additional glucose control in this setting, we have a wide range of drug classes which can be chosen, but reminding that pioglitazone and saxagliptin are contraindicated, are not recommended in patients with diabetes and heart failure, as we know. Last type of pathological conditions which can be present concomitantly is diabetes and chronic kidney disease. And again, we know that if we want to reduce cardiovascular risk in patients with diabetes, we have to implement a statin-based regimen. If we want to reduce kidney failure, kidney deterioration, we have to have ACE or ARB on board. But if we want to reduce concomitantly kidney failure risk and cardiovascular risk to finerenone, to blood pressure control, we have to add an SGLT2 inhibitors with a class 1 type of recommendation. Now, I would like to, after giving all this detailed information about treatment, I would like to focus your attention on another important issue which was dealt in these new guidelines, the cardiovascular risk assessment in diabetes. And this is a novel concept because we are used to consider patients with very high CV risk, so patients who have already experienced a cardiovascular complication. But there are patients with diabetes without atherosclerotic cardiovascular disease, without other target organ damage. So they are in a more earlier phase, and we need to be able to assess the CV risk in these patients. And by using this new risk prediction tool for patients with type 2 diabetes, which is taking origin from the SCORE2 algorithms. The SCORE2 algorithms was basically predicting the 10-year risk of a fatal, non-fatal cardiovascular events across all the European population in region with very low, from region with very low to region with very high risk, as we know. And the classical predictors for SCORE2 to assess cardiovascular risk in the general population, the classical predictors were age, sex, smoking, presence of diabetes, systolic blood pressure, total and HDL cholesterol. Now, basically, to this general risk tool, we try a new risk prediction tool for the population of patients with diabetes, and this was an adaptation of SCORE2 for the general population, only for individuals with type 2 diabetes, by adding some selective predictors, such as the age at diabetes diagnosis. We know that it's very important when a patient starts its diabetes career, if it's early on or later at the later stage. And another predictor is the glycated hemoglobin and the glomerular filtration rate. So by adding to the general predictors I just mentioned, these three, we may identify the cardiovascular risk of a certain patient with type 2 diabetes. And this SCORE2 diabetes was calibrated by using data for more than 200,000 individuals with diabetes taken from diabetes registries, cohort studies, electronic health records. I work in a country like Sweden where you know that the disease registries are extremely well developed, and we can really take into consideration all the characteristics of any type of disease. And then after this first calibration, we validated SCORE2 diabetes by using individuals, more than 200,000 individuals with type 2 diabetes from different countries in Europe, Sweden, Spain, so from north to east to west, Malta and Croatia. And after this double validation, internal and external validation, we came up with this recommendation in patients with type 2 diabetes without symptomatic atherosclerotic cardiovascular disease, without severe target organ damage. It is recommended to estimate a 10-year CVD risk by using SCORE2 diabetes. And because we can see that by using this SCORE2 diabetes, we can have all the range of risk from low risk to very high risk. And it is clear that these four categories have important implications for treatment strategies. Here it's another graphical description of why it is important and how by this recommendation we may reduce cardiovascular risk based on the 10-year CV risk estimation by SCORE2 diabetes. If we move from your left to the right, on the left we have low a moderate risk, which is no atherosclerotic cardiovascular disease, no target organ damage, with a SCORE2 diabetes less than 10%. If we are in that type of, we have that type of patients in front of us, then metformin is the first class of treatment, because by using metformin we may delay the progression of the cardiovascular risk of our patient. Then we move to the center of these figures, and here we are in a data-free zone, because here we are dealing with patients with high risk, without established cardiovascular disease, without target organ damage, and in this category of patients, the trials are not helping us. Because, as I told you, the trials have recruited patients with multiple cardiovascular risk, target organ damage, or established cardiovascular disease. But here we are in a gray zone, and in this gray zone, we have class 2B recommendation for metformin, for SGLT2 inhibitors, and GLP-1 receptor agonists. Whereas for the very high risk, green light to the two classes of drugs I've been showing you. So basically, we can say that these guidelines are an excellent tool to implement evidence-based, person-centered treatment strategies to reduce cardiovascular risk in our patients with type 2 diabetes. Now I would like to focus your attention on, we have been talking about obesity. It was shown by my colleague before that obesity is the new smoking. And we know that GLP-1 receptor agonists, in addition to have this cardioprotective effect, they may develop some effect on body weight reduction. And how this is taking place is taking place because they have a dual action, a dual effect on the central nervous system and on the periphery. I mean, they slow gastric emptying by acting on the periphery, on the bowel, on the stomach, and they induce postprandial satiety, reduce appetite and hence food consumption by working on the hypothalamus, on the limbic reward system, and on the cortex. And because of this dual effect, there is a very powerful weight control induced by GLP-1 receptor agonists such as semaglutide, and indeed the trial step 1, which recruited adults with obesity, no type 2 diabetes. As you can see, semaglutide 2.4 milligram once a weekly as compared to placebo on top of lifestyle intervention was able to reduce significantly the body weight of these individuals, and such a body weight reduction was persistent in time. And because of this, the results of step 1, there was designed and started another trial, SELECT trial, which was designed to test the effect of GLP-1 receptor agonist, SEMA, on cardiovascular outcomes in people with overweight or obesity. The participants which were recruited in this trial had a BMI above 27 kilograms per square meter and a history of cardiovascular disease, but no diabetes. So they were not patients without diabetes, and the primary composite endpoint was the classical one. So basically, this trial, in a way, helped us to expand our understanding of obesity management in this context. And indeed, just a few weeks ago, really last week, the results of this trial were presented at the American Heart Association Congress, showing that semaglutide, 2.4 milligram, reduce the risk of MACE by 20%. There is an hazard ratio of 0.80, which is very highly statistical significant reduction. And as you can see, such an effect starts very early on. The curve, the survival curve, diverge very early on after a few weeks of treatment, as it was the case in trials with patients with diabetes, because we have seen that GLP-1 receptor agonists after 1.5 months already are having an impact on the reduction of cardiovascular event. Now, just the last slide. After talking about these fantastic results of the trials and this ideal scenario, let's try to address what is happening in the reality of our European population. Here we have a EuroAspire survey, a survey of the European Society of Cardiology. EuroAspire is an acronym which is standing for European Action, Secondary Prevention, Intervention to Reduce Events. These are all the countries which have been involved in this survey, 27 countries, recruiting patients with coronary artery disease, more than 8,000 patients. And here we have the results of the patient who had dysglycemia, so either patients with diabetes or pre-diabetes, which were able to reach the different treatment targets we preach in our guidelines: LDL cholesterol, blood pressure, glycated hemoglobin. And you can see that very disappointingly, the targets that we are clearly writing in our guideline are reached in a very low percentage of this individual with dysglycemia, either with impaired glucose tolerance or non-diabetes. And so basically we can conclude that the multifactorial management of patients with coronary artery disease in Europe is far from satisfactory. And why is that? I mean, if we look at the percentage of patients which are using these newer glucose-lowering drugs, in which we have prescribed either GLP-1 or SGLT2 inhibitor, very, very low. And then we ask ourselves, is the situation the same or different across the Atlantic? I mean, we always look from this side of the Atlantic to the other one like they are better than us. Some of this evidence is not really very showing that, because here we have a US database which is showing that drug treatments such as lipid-lowering cardiovascular drugs, glucose-lowering drugs, which should be used altogether, a type of multifactorial management, you can see that only 7% of patients with coronary artery disease are receiving such optimal medical therapy, and this is the case also for a US insurance database, very poor, having on board all these three different therapies. So basically, I think it is really time for action. We have the knowledge, we have the evidence, we have the pharmacological tools, but we have to put and pull together and have a real, I mean, such an adequate management can only be accomplished if we are able to build bridges across specialty borders. So we need really to work in team of cardiologists, diabetologists, primary care physicians, in order really to achieve the best for our patients. Thank you very much for your attention.
Thank you, Professor.
Thank you very much. So the questions, you can write them in the written form, and I think that the presentation was truly interesting. The second report is by Barnosha Gazatova, the role of metformin in the treatment of prediabetes and diabetes. We have good timing, and we have like 20 extra minutes, and I think that we will have a fruitful discussion. At least I have 5 questions for now. Good evening, dear colleagues. I would like to say that if Professor Constantina mentioned the construction of bridges, I would say that there are very fragile limits between cardiology and endocrinology. We hear the representatives of cardiology. Here we discuss the treatment of diabetes and the medications that are used in the diabetes treatment. The topic of my report today is the role of metformin in treatment of prediabetes and diabetes, and I would like to say, so that's the disclosure, and I would like to say that speaking of the spreading of prediabetes in the world, this year in 2023, the International Diabetes Federation is supposed to publish the map where the prediabetes patient number will increase, of course. And if we see the prediabetes, we have 2 conditions. This is the bad fasting glycemia. That this research to me. Here the co-author is Gulnara Rahimova. This research was dedicated to identification of the glycemia, of the increased glucose level at the fasting test with the people with obesity. And this bad fasting glycemia, it's mostly expressed at the people with the bigger mass, and also it contributes to the increase of the number of people with diabetes. What was interesting in this research, we were co-authors together with Gulnara Nishanovna here about the identification of patients with the obesity and the overweight patients. We can say that among men, there was more the extensive body mass, and among women there was obesity more in more cases. And what is interesting among the people with the bigger mass of body mass, the potential diabetes increases 120%, but the obesity with it, diabetes increases for 10%. We should say that the cardiovascular risk, it appears at pre-diabetes. So the cardiovascular disease is not only the background of diabetes as microvascular when the diabetes starts, but when we already have the glucose tolerance not working well. If we look at the improve of the relative risk of the cardiovascular diseases, the decompensated, what is the amount of the cases of CAD. If the history there was no diabetes, that the glucose level more than 7, it gives a bigger amount of the CAD. Again, if we look at the glucose level 3.9, 5.6, the amount is sharply decreasing, and it increases with the indicators of more than 3.9, because hypoglycemia is the very powerful factor of the CAD, of the coronary artery disease. Pay attention here exactly at diabetes. The cardiovascular diseases amount is increasing and the mortality increasing. And while entering into diabetes, those numbers do not change sharply. That's why the timely diagnostics and the treatment on the background of the pre-diabetes has such importance. And who and how often should conduct the screening? We know very well the risk factors that lead to diabetes type 2. They are the foundation for the metabolic syndrome, and if it was supposed that each 3 years the people elder than 40 should do this, and the American Diabetic Association now proposes to screen the patients over 30 years. And today we see the patients who are 30, 31, 32 who have abdominal obesity, and they have the high risk of both cardiovascular diseases and pre-diabetes. I will describe the old, I gave here the old algorithm. This is American Association of Clinical Endocrinologists. The world doesn't stop at the same place, but this is like a discussion. But here the treatment of hypoglycemia is at the first place. At this treatment there is metformin. Of course, I would move the agonist of the DPP1 receptors at the first place, because exactly they, for today, are the medication drug of choice, because we decrease the weight of the body, and we look at the dosage of 2.4 milligrams and liraglutide 3 milligrams. But the side effect of these medications, of course, limit them for the use of people without diabetes, for those people who didn't have the diagnosis yet. In this regard, I would like to say about a biopsy that has the effect to like the cutting of the guts, but it has a lot of side effects. But of course, it's clear for us that the mainly here we should change the lifestyle. This is the rejection of smoking, and if we speak about the diet, of course, it should be like Mediterranean diet, and our republic is rich in fruit, vegetables, which unfortunately our patients do not take very often. And there are a lot of fats, good fats, and we have the region with the high birth rate, and there is the violation of the diet and the use of the fats. This is the big factor for the diabetes. And there should be the physical exercises and the take of the vitamins and micronutrients. The optimal correlation of the products of the daily diet is clear for you, it's well known, but do many of us follow this optimal ratio? Of course, no. And our task here is in conducting this prophylaxis and prevention work. If we speak again, going back to the recommendations on the prevention of the type 2 diabetes, the diabetes prevention program is the foundation for the research, in addition to the change of the lifestyle and improvement of the physical activity. Of course, it is farm therapy, and it includes metformin. If we speak of the 2023 standards, here the therapy of with metformin should be considered with a high risk of diabetes, with the presence of the risk factors which we were discussing. And here it's more effective in the younger age, 25, 59, with body mass index less than 35. The glucose, fasting glucose, more than 6.1, a high level of glycemia hemoglobin, and the standards of 2023 reapproved the place of metformin in the pre-diabetes treatment. What I want to say here that it's not by chance that the standards included metformin, because the multiple research they have proven the role of metformin in the decrease of type 2 diabetes. This is DPP, this diabetes prevention program. And in this research, the 10-year review after taking metformin in these exact groups that I have mentioned, the age 25, 44, 45, 59, it's more effective in the younger age, and with age the effectiveness of metformin unfortunately decreases. And if we say two of this research of diabetes prevention program that was conducted within 3 years, and where we have noted the decrease of the risk of diabetes for 53%, we should say that for the 10 years of review and 15 years of review have demonstrated that with the people with the gestation diabetes, they have the 41% decrease of the risk of diabetes. And of those people who had the higher indicators of hemoglobin and fasting plasma. If we speak about saturation, and we should speak about two molecules of the immediate freeing, you know it very well, this metformin. And today in the country we have the prolonged freeing, like once in 24 hours, and the dosage at pre-diabetes, it is 1,500 milligrams per day, and at this we should conduct the control each 6 months of the fasting plasma, and each 12 months we should conduct the glucose tolerance test, or I here recommend to test the glycemia hemoglobin, and at the prescription of metformin it will contribute to the later appearance of diabetes, and this is what we aim at. Speaking of algorithm and the place of the metformin in the treatment of diabetes, we should say that based on the recommendations of the American Diabetic Association, unfortunately, metformin it is losing its leading position. It doesn't take its leading position that it was taking for many years. But the Council of Experts, as we discussed, especially for Uzbekistan, as an exclusion, as like a star note for the first line, we have left metformin for today, because taking into account the high frequency of prediabetes and diabetes for Uzbekistan, now it takes the first place for now. And you have heard probably of the medications that have the high level, and the level of evidence is also high. These are GLP of peptides and CGLT medications, 1A, 1C. I will not repeat this again on these slides, but I want to say that all the research that are related to cardiovascular safety of GPP1 agonists, you can see the quantity of combination with metformin 76, 73, 77, 81. These are the research that have proven the decrease of the cardiovascular risk of those medications. And in terms of NGLT2 inhibitors, they all were combined with metformin. That's why its safety, it was proven by these researchers too, because the monotherapy wasn't used, they were used in combination. And if we speak of the decrease of the cardiovascular risk, if the additional control is required in taking metformin, if the additional control is needed for the glucose level in blood, we can look at the opportunity of prescribing of pioglitazone. But again, we love this medication very much, it's very good, but it has terrible side effects. On one hand, this is the increase of transminase, like it's related to liver, and then this, on the other side, this is edema. The people with the cardiovascular diseases, we understand that they have the complications of edema. They will become even worse, and that the heart failure, this medication is not recommended at all. If we speak about the patients without the cardiovascular diseases or the severe conditions of the target organs, we can look at this medication for the decrease of the cardiovascular risk, and for the patients with the high and very high risk, and for the patients without cardiovascular diseases, but with the count of the 10-year risk over 10%, we can look at the treatment with CGLT2 and GPP1 receptor agonists for the cardiovascular diseases treatment. If we look at the protective features of metformin, of course, this is the effect on the lipid exchange, the oxidative stress, and the decrease of aggregation as presented in thrombocytes and the cells of the high quality. And here we see again that it's absolutely safe, and the combination with innovative medicines is recommended to the diabetes patient. Again, speaking of Speaking of the focus on the prolonged freeing, we understand that there is a smaller amount of the side effects, and this contributes to the compliance of the patients, and it also leads to the decrease of the macro and microvascular complications. That's why, speaking of metformin, in 2017 we celebrated the 60th anniversary. Today it's 66 years of taking metformin. This is our yesterday, today, and tomorrow. It is effective and safe, and which is also very important, it is cost effective, and it also proves that today we have the medication in the form of the immediate and prolonged freeing, and of course it simplifies the work of both cardiologists, endocrinologists, and the general practitioner.
I'd like to say that up to date in Uzbekistan, it's the first line medication for treatment of pre-diabetes and second type diabetes. Thank you for your attention, and now we can start a discussion session. While there are many questions, would like to ask our international experts. So we've discussed two main areas. First of all, arterial hypertension, and also we discussed the cardiovascular diseases with diabetes. And my question to our international experts: what is primary, egg or chicken? What is more primary, hyperglycemia or hypercholesterolemia? In few words, can you discuss this? Professor Leif Dechent and Francesca Constantino. What do you think is more primary? Because my next questions will be related to this.
We have now seems not to be on anymore. I mean, we have overwhelming epidemiological data that the overlying mechanism is obesity. I mean, it used to be that more people died because of not eating enough, because of hunger, and now we die of eating too much. So probably if we tackle obesity, we will get probably even more the diabetes problem abundant and a lot of the hypertension. However, hypertension can and will develop independent of obesity. But for me, the overarching problem is for sure obesity.
Well, I would like only to mention one data. In patients with coronary artery disease, only 30% of them have diabetes. So we are, I mean, again, where 70% of them, they have obesity and a condition which can be reconciled with the pre-diabetes definition, glucose intolerance and insulin resistance and overweight. So I think I fully agree with my colleague. I think the common denominator, which is both leading to impair blood pressure and impair glucose tolerance, obesity plays a major role there.
Thank you very much. And now tell me, and is this due to cholesterol? Is the main reason to develop the atherosclerosis of the vessels? Is the main reason is cholesterol? Because I've heard that we have, there is the Professor Ralph Decheren, the place where you live, there is cardiologist, Axel, I didn't hear the family, and he has his own theory of atherosclerosis development. And he has a different theory on the development of atherosclerosis. So can you tell us how the cholesterol is related to the development of the atherosclerosis? Can we blame cholesterol in the atherosclerosis?
on the ESC this year, there was one highlight study, which was a summary of 1.5 million individual patient data of studies for 40 years all over the world, and with 5 risk factors: blood pressure, BMI, diabetes, smoking, and age. They could not test exercise. We can explain worldwide 50 to 60% of arteriosclerosis. And now we can discuss with this what is most important from these 5 things, plus exercise, which we could not test. And we can discuss what is the missing 40%. And so for me, these 5 things are equally important. If I have to make my personal ranking, it is cholesterol plus lack of exercise for the cardiac vessels. For the heart, for the brain vessels, it's the blood pressure, and for the peripheral artery disease is smoking more important. Axel Haverich is a wonderful surgeon. I was a student when he was a senior physician in Hanover. However, and this counts for everybody, without data, you are just a person with an opinion. I accept his opinion, but he needs to spend the rest of his life on delivering data that his opinion on which are alternative to what our common knowledge is comes. So far, I respect him as a person. I would always let me and my family operate on him, but on this sort of arteriosclerosis he has, I wait for more data.
If I may add, I think we should not indulge in this game to try to understand, to try to establish a hierarchical power of different risk factors, because if we do that, we lose time. I think we need to intervene. We have the tools. I've been showing you that we don't do it so far properly, and there are no excuses. We should do it because we know these are the major guilty players, and we should address and tackle them.
I would like to comment one more thing. I really like your approach, because I think what you are trying to tell or to ask is prevention is more than prescribing drugs. But we need the drugs, but there is something what has to come from the patient. What can the patient do for himself? And if we get even more holistic, and perhaps now is the time, because we have some time, I was listening to a talk from Detlef Ganten, elderly guy who trained me, 80 plus, and he said, I have a formula of health. Health is a function of lifestyle, biology, and environment. And we are the experts on lifestyle and health. This is what we studied. And we have to bring it to our patients. And probably environment is a third thing. And if we, as scientists and physicians, are not able to explain it to the patients, bring it to the patients, like we explain them lifestyle and biology, this will be neglected.
Thank you. I have third question to you. As you're leading 2 specialists, you have your own patients. For example, you have hypertension, a patient with hypertension, with CVD and diabetes. What are your first recommendations? Really important for me to listen your experience. How you start your recommendations to such kind of patient? What you tell them first? If a question is not clear, do you immediately prescribe the medications that you already presented today, or you start from different things?
You say a patient with established atherosclerotic cardiovascular disease, diabetes, hypertension. Yes. Well, I will not have any doubt in starting treatment with drugs such as GLP-1 receptor agonists or SGLT2 inhibitors, which may also tackle the blood pressure, not only the glucose levels, with some millimeter of mercury of reduction. Of course, you need to combine other treatment, but I suppose that this patient has already on board antihypertensive treatment.
I think you allude to a very important point, that this is communication to the patient. And in most of my patients, I mean, they all can remember the good old school times. They all have children or grandchildren who are in school. So go back to this magic 5 things: not to smoke, exercise, overweight plus diabetes is somehow is very closely connected, cholesterol and blood pressure. And let's see where your marks are. And the minimum you have to have 1 is the best and 5 is failing. You should try to get a 2 in every mark, and sometimes you will only have a 3. And then some of the things can be very easily achieved. I think most of our patients, if we give a fixed combination of rosuvastatin or atorvastatin with ezetimibe, most of our patients will be around 55 to 70. If we give a triple blood pressure combination, most of our patients will be in a blood pressure of roughly around 140. I tell them, because I don't want to lose them, now the minimum goal is you do not increase your weight. Don't bother about losing weight at the moment. Stay with your weight and increase the exercise. And, well, stopping smoking is philosophy, something else, and it's another question. Some people, we have to accept that they will not stop, but try to convince them. I mean, we have good data. Even if you just tell your patients, I want you to stop smoking, 10% are stopping. I would like to have my wage to be increased by 10%, which will not happen. But 10%, I mean, it's not enough, but always try to attempt.
Thank you. And Ralph, a question to you. We have, in endocrinology, we have phenomenon of metabolic memory. And in the treatment of, do we have this effect in the treatment?
But
This is not it's for you, my question, for audience. How we need early treatment, how it's important.
Please. Well, I mean, we didn't discuss it today. I mean, I'm very much interested in metformin, but more on an experimental level. I think the data have been very clear, but the mechanism of metformin being preventive is perhaps independent of the HbA1c lowering effect. There's very good data that metformin has a positive effect on the microbiome, opposite to what antibiotics are, which have a very negative, perhaps long-lasting effect or lifetime effect on the microbiome, and metformin is beneficial. So the microbiome of healthy and obese people are completely different. However, if they are on metformin, they go much back to the normal one. How important this is for living longer and living better, we need to know. And the second thing on metformin is it's linked to longevity. And the studies are ongoing, and it might be very interesting if, for example, this turns out to be positive via the metformin, via the AMPK pathway. So I think there is something, what is memory, also for metabolic, probably mediated by the immune system, but perhaps also by the gut-brain axis, I would call it.
I would anti-hypertension treatment. Does this mechanism work in endocrinologists in hyperglycemia? This mechanism work, but in hypertension, in the early treatment or prevention, is this? Do we have such a mechanism like in endocrinology?
Data that if you're pre-hypertensive, that if you then give a RAS blocker, it is working. However, the number needed to treat is so high that at the moment this is not recommended in guidelines. These effects, what you describe and which are well known in immunometabolism, are weakly described in animal models. So at the moment, I think yes it is, but it's nice, but it's mice where it has been tested. So we have to do more work.
Question for auditory. Особенности лечения сахарного.
The peculiarity of type 2 diabetes treatment at the group of patients over 70 years. So you can, I think, your opinion, both of you can share your opinion. So treatment of patients with diabetes whose age is more than 70. I would say the aged patients is a very high risk group in terms of sudden reducing the glucose level. That's why the compensation level will be different at the comorbid states patients. That's why we don't say that it's 7.5 and in cognitive disturbances 8.5, and currently high-risk comorbid patients, they don't have any indications of glycated hemoglobin, and if diabetes just started in those patients, then the safe medications are PPG4 inhibitors. They are safe using in combination with metformin, but if they have CVD high risk, if they are comorbid patients, of course, CGLT2 inhibitors, there is high risk of CVD, and those inhibitors and agonists lower level because older people, they have sarcopenia, and that's why we don't see obesity here. That's why CGLT2 inhibitors, we can use them. Maybe my colleagues can add something.
I perfectly agree. I think it's important to tailor the glycosylated hemoglobin target according to the age. We have to not to have this ambitious target that we are young patients, and this is clear for all the problem you mentioned. Again, SGLT2 inhibitors can be a class more appropriate to not only to reduce glucose levels, but also to try to invest in protective mechanism, both at cardiovascular system and also in the microcirculation, so for kidney disease, which is common comorbidities in old elderly patients.
К этому вопросу скажу. Понимаете,
I'd like to add, if we do early prevention of diabetes, then we will have such patients over 70 years. And since we are finding such diseases at later stages, and Professor had the slide that importance of cooperation between cardiologists and primary healthcare doctors, we can treat those patients better at early ages only when we identify diabetes at early stages. And we have bad statistics. We have 6.8 million morbidity from the diabetes, and this is very high figures, and that's why this was positive question. We hope that we can treat patients over 70, 80 years, but only in the condition that we can identify such diseases at early stages, so they don't have complications at the age of 70. And
And the second question, the question to Francesco, have you had in your practice the significant decrease at the patient, the significant decrease of the blood pressure with the diabetes patient with a normal body mass through with CGLT2 medication, CGLT2 inhibitors prescription?
The SGLT2 inhibitors may reduce of some millimeters of mercury the blood pressure, both the systolic and the diastolic blood pressure. So this is common in clinical practice in our experience. Clear, there is that, but it's a minor effect that you can achieve with SGLT2 inhibitors.
I completely agree. You cannot substitute an SGLT2 inhibitor for a thiazide or thiazide-like diuretic. There is a small effect. I think it's independent of the weight, at least that's what I see. But there's one thing where I see an additive effect of the SGLT2 inhibitor, and this is in heart failure if you combine it together with a loop diuretic. So this sequential nephron blocking, which we used to do, or which you sometimes have to do with a loop diuretic and a thiazide plus spironolactone, since we introduce SGLT2 in heart failure, my impression is that we lose less thiazide for sequential nephron blockade, and we get much better decongestion. Is this also your impression?
Yes, definitely it is. I think the combination makes sense, and you may achieve better results, not only in terms of blood pressure reduction, but in general, nephroprotection.
Следующий вопрос.
The next question. Can you give more details about the side effects of liraglutide group and their prescription for the body mass reduction? Could you give more details? So we had a lot of details, but our audience wants more. Yeah, I want to say that, of course, the mechanism itself of the agonist of GPP1 receptors, there they have that feature that there is the holding of food in the guts. This gives the feeling of sickness and vomiting, and the sickness among this patient is not bad; it is good. This contributes to the consumption of smaller amount of food, but I want to say here, of course, the main part here is that we should conduct. And a question to you, patient has the problem of thyroidectomy and obesity of the second type. Can she be prescribed with metformin? There is a big part of the research it's dedicated to the work of metformin and prophylactics of the oncologies and the cancer, and that's why it's completely safe. But this disease should be controlled annually, but metformin, of course, it can be prescribed. Now, the question to our two experts. Have you had such a patient, like optimistic question, at the age of 90 with body mass index 35, like who was already lying and who didn't have neither hypertension nor diabetes second type nor atherosclerosis of second type? Well, it's a too young, even too young patient. It's for our foreign experts. 90 years. Yeah, it's a very optimistic question. 90 years with no diseases, but this person has cannot stand up. He or she is lying all the time. Have you had such patient? But with such risk factors, people do not live so long. They do not live until 90 years. Like No, this patient doesn't have hypertension nor diabetes. I'm reading the question as I have it written. When you are giving your question, please, we all are here like reason we are here, yeah, to have the constructive discussions. Have you had such a patient at the age of 90 with a body mass index 35 lying, and the patient who doesn't have either hypertension or diabetes or atherosclerosis? This is a very optimistic question. Is it really possible, actually? Have you ever had such a patient, such case?
Это, наверное, самый сложный вопрос, который они встречают.
Yeah, it's probably the most difficult question.
From the research point of view, I think this longevity and at what age you call it physiosclerosis. And I would say I have not had one of these patients, because everybody who has no vascular problem, I would call it now, and is diagnosed, I mean, you can always be underdiagnosed, is lean. Because, I mean, if you look at people who get over 100, they are never obese. Usually it's not the male, so it's female women who have a BMI of definitely less than 25. Some even say roughly about BMI of 20. So I study elderly people, 90 plus, but they never have a BMI of 35, or very rarely, without any vascular problem.
Well, I think I completely agree with what Raf just said. I would like to say that maybe his diabetes or dysglycemia condition is not recognized. I would suggest an oral glucose tolerance test in this individuals, because it's healthy, only obese. But for sure, with an oral glucose tolerance test, you will be able to detect some glucose intolerance.
But if these patients exist, and this runs in a family, we can learn a lot of that. It was families from Italy who had very low LDL levels and had nothing wrong with the LDL receptors. And then I read it, I was in the lab, it was a Nature Genetics paper. I found it terrible boring that there's some little protein called PCSK9 inhibitor, which they are not having. And it took 10 years from this observation of families in Italy who live long with good cholesterol levels to a wonderful new medication. So if these people exist, and if there's something genetically, we can learn a lot for everybody of us.
Спасибо. Вопрос к Франческо.
So the question to Francesco, is there a patient with the decreased freeing fraction, and is there a sense to prescribe sabugaltril vasactan and CGLT2 inhibitors? Can we expect the more expressed and the more fast result with such combination?
You mean a patient with heart failure?
Reduce ejection.
Patient, yes, yeah.
And whether we can expect better results by a treatment with a combination of ARNI and SGLT2 inhibitors. Definitely yes. I mean, we can and we should combine this type of treatment in FRF patients, because there are trials which are indicating, I mean, trials with SGLT2 inhibitors, subgroup analysis of this trial have shown that patients with SGLT2 inhibitor and with ARNI on board are doing even better than without this drug.
I mean, these data come from computational science, we have to be honest. However, the difference of saying, okay, give him a bit of an ACE inhibitor, a bit of a beta blocker, versus giving these four giants, as they are always called, is really substantial. If you start in a 55-year-old, he will live more than 8 years longer compared to a bit of ACE inhibitor, a bit of beta blocker, and if you start with 65, it's 6.3 years. So it's really, we should not be inert not to give it just because they feel they have little symptoms, because, I mean, it really makes a difference.
Спасибо. У меня
Thank you very much. Now I have a question to our specialists. What do you think about bariatric surgery, like cutting the stomach, the guts? This is very popular nowadays, and that was mentioned by our last speaker. What is your opinion about this? What can you say?
I want to
Yes,
do
I think this is. There are studies which are pointing out that bariatric surgery has a protective effect and for cardiovascular events. But now, as I presented, the SELECT trial with GLP-1 receptor agonists are even showing that by treatment with a drug, you can prevent major cardiovascular events. So maybe I would say why you have to undergo an invasive procedure when you can get the same similar results by pharmacological treatment. Of course, eventually for most, very high and severe obesity, you may improve your quality of life by a gastric bypass surgery, which is not negligible. So it's important to consider this option too.
It belongs into the hand of a specialist team and not only the surgeons, because, I mean, they perhaps, I mean, there's a lot of money in it, but I think if we leave these people with a BMI of 45 or higher alone, diet will not work. This has been shown 100 times. And sure, the GLP-1 receptor agonists change the field a lot, and definitely they have to be put before. But in Germany, if you want to do it, you have to go through a procedure which is more than a year, and there's a lot of psychological stigma and support, probably both, before this is allowed. But I think it has a position, but it's a position which has to be accompanied by really specialists and in a team.
If I may add, I don't think we will ever have a head-to-head comparison between a GLP-1 receptor agonist treatment as compared to gastric bypass surgery. I see it very difficult, this kind of trial.
Вопрос из зала.
So the question, I guess it's probably for cardiologists, the patient who had also 110/70 blood pressure had the sharp increase 160/100, and there is the violation of the blood circulation in the brain. And now, after treatment, the stable pressure 160. Should we prescribe any medication? The patient is afraid to have the increase of the blood pressure. The BMI is 20. The BMI is 20, and the 100 to 60 of the blood pressure. Here, I think that we should have the individual approach to each patient. We should take into account the other factors too. If we take the age, it's 70 to the BMI, the patient lose weight. Any hypertension medication will lead to the decrease of the blood pressure. Taking into account the age, the 72, and probably there is atherosclerosis, the CAD, and we can prescribe the medications that are used at CAD, and the hypertension, we can prescribe beta blockers that they can preserve the CAD, anti-CAD effect. And here, I guess we should look at the individual situation. Maybe our colleagues can add here.
Patient 72 years, index body 20, yes. And he has arterial pressure 100 to 60 millimeter, systolic 100, diastolic 60. If necessary for antihypertensive therapy for these patients. And in anamnesis, he has stroke. No stroke, maybe it is transitory ischemic attack was. It is not, we haven't information.
It took till 2018 till the first guideline gave us a recommendation. If we as physicians are responsible for blood pressure of less than 120, there's no substantial benefit anymore. So everything with our blood pressure medication, what we have, if the patient has below 120, we are now advised to slowly reduce them a little bit. And if somebody has a blood pressure of 100, I would definitely not recommend blood pressure medication. And after a stroke, where cerebral autoregulation has been altered and is not functioning very well, I would like to see this patient who is not too old more in a blood pressure of 120 to 130 after a stroke or a transient ischemic attack. I would definitely like to have him less than 130 if possible, but a bit higher than 100. So my would be 110 to 130 in this patient. If he has other reasons why he is frail, having orthostatic hypotension, I would go 120 to 140. But I would, in this patient, I would slowly reduce the blood pressure medication.
Понятно, да, ответ, я думаю, да, в таких...
Okay, the answer is clear, right? In this cases, the BMI, the pressure, we shouldn't prescribe it. Okay. Can I add here too? As cardiosurgeon, first of all, I would look at the reason why the pressure was 160 to 100, which has led to the stroke. I wouldn't think first about the hypertension medication prescription. We need to seek for the reason. Maybe there was arrhythmia. Maybe there should be the prevention, like prophylactics, like anticoagulants should be prescribed. Or maybe aspirin 0, 125, or like even not Trambas, or just aspirin. I would make the Doppler of the vessels or of the neck. That's what we should look at first, not as doctors, not as nurses. We shouldn't think about the medication. We should see the reason. We should see why it happens. That's my opinion. We are done with the questions from the audience. I have one last question to Francesco. First of all, I would like to say that the detailed analysis of the recommendations of 2023, we are grateful for this analysis. This is very useful for cardiologists and endocrinologists, but we have here the family doctors from polyclinics, the general practitioners, for whom, of course, the hypoglycemia medications prescription is very important. They do not have, at some sites, at some locations, they do not have the diagnostics opportunities, what would you recommend to be oriented at for the primary care doctors at the choosing of hypoglycemia therapy? Can they be oriented to what you have presented in your presentation, score 2, depending on the risk of having the cardiovascular diseases at prescription of those medications?
Very important issue because it's going back to my concept of collaboration across primary care center and hospital cardiological type of teams because it's very important the assessment of cardiovascular risk before starting any type of treatment, and many times this cannot be done in a primary care center, but the patient has to be sent to assess CV risk. I mean, because you need some diagnostic test. And again, there should be a teamwork which it's easy to say and not easy in reality, but first screening can be done by the SCORE2 diabetes risk assessment tool. But then if you need to deepen into the understanding of the condition of the patient, then the patient has to be referred to cardiologist.
I can deeply support what was said, and this is also a big problem in Germany. I think before the SGLT2 inhibitors, we cardiologists were not interested in diabetes. All what is about metabolism was for the others. We were interested in hemodynamics, resistance, and all these things. And the SGLT2 inhibitors have changed that tremendously. Only a few people, like Nicolas Marx, had been experts in this as well. And even now, it's not clear how we really, should I as a cardiologist, I mean, I surely prescribe SGLT2 inhibitors. The HbA1c of 10 milligrams DAPA or 10 milligrams empagliflozin is not much. It's 0.4, 0.5. 0.6 is the 25 milligrams empagliflozin. Ranolazine, which will be on the market probably here in 1 or 2 years, also is reducing the HbA1 of 0 to 0.6 without side effects. Has never been interested in cardiology. So we cardiologists have to learn, but can I prescribe a GLP-1 agonist? You would say, yes, there's no side effects, but the HbA1c goes down by 1.0. But when do I see the patient the next time? And who has been taking care about the diabetes before? Should he prescribe it? And I have now tons of communication problems where I say, this patient has diabetes and cardiovascular problems. This is why he sees me. He has an expert indication for that. I am happy to prescribe it. So it goes to my bill later on. But please initiate it because you have been taking care of the HbA1c. And I should not interfere with a very potent anti-glycemic drug. Nothing happens. Patient comes back. Whatever I have written has not been listened to. So, and this is an ongoing problem. And even I don't know, should I now start and say, okay, you didn't start, so I now start? It's still a challenging thing.
Yeah, but I would say that the glucose lowering effect of this drug, somehow these drugs are clever because if the patient starts with already not too high glycated hemoglobin, it doesn't really lower it very much, but you get the protective effects or these pleiotropic effects, which are important. So as cardiologists, I believe we should not be worried to prescribe because we don't see them in a control visit and we are not able to control the glycated hemoglobin. Of course, we have to avoid hypoglycemia, but I would not be so worried with these two classes of drugs. That I don't know whether you agree with.
I'd like to say that, of course, we missed the score 2, and it helps. Actually, the score 2 calculator can help doctors to assess the risk, but the duration of diabetes and the presence of CVD, this is teamwork. If cardiologist didn't screen, the patient might not be able to, let's say, find his CVDs, and when we can implement this score 2 calculator, it will simplify the work of the cardiologists, endocrinologists. And I have just ethical question: do the family doctor have the right to prescribe SGLT? Metformin, yes, 100%. Regarding CGLT2, if family doctor sees the heart failure, then this is direct indication, taking into account the situation, let's say, in the family polyclinics, in the, let's say, rural hospitals. They don't have the possibility to identify the heart failures, like type of, what they should do in this case. Yeah, asking the international experts. You say it's teamwork, but the family doctors, they work alone. He should refer a patient to somewhere, or what?
I mean, two aspects to that. First, SGLT2 inhibitors are easy to use. You need the creatinine clearance and the proteinuria. Then you have the indication for the kidney protection. And heart failure is a clinical diagnosis. What you need is the dyspnea and some sort of cardiac involvement. Don't wait for the echo. You need to wait for the echo before you give an ARNI, before you give aldosterone blocking agent. But for example, a BNP, I know it's an expensive parameter, but I think if this patient has an increased BNP plus shortness of breath, I think the indication for an SGLT2 inhibitor is given. And even if you do not have the BNP, if the physician doctor who has a lot of experience can exclude other reasons for shortness of breath, and if BNP is too expensive, an SGLT2 inhibitor perhaps is also not a bad idea. I would very much warn from starting therapy if you have the problems for further diagnostics, because there was one study which I do not understand, but it was tremendously telling us a lot. It was the Dan Cavis study. So 20,000 adult people between 55 and 65 got a calcium score, which means a good ECG. They got ankle brachial index, which means good blood pressure. They got their blood sugar values measured. They got their cholesterol level measured, and they got advice. If you had an ECG, atrial fibrillation, they said, go to the doctor because you need anticoagulation, blah, 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 versus standard. And I would have given 2 months' salary that this 15,000 patients who had this better screening would live longer after 5 years. 0. It was not significant. So what is the best diagnostics compared to what we can do, like measuring proteinuria, measuring LDL, measuring HbA1c, is still a question.
Ну, я хочу добавить вот.
I'd like to add that we are a little bit behind from cardiologists in terms of prescribing SGLT2 inhibitors. In 2019, 18, and 2023, the cardiologists are a step ahead, and standards on treatment for diabetes patients, they were lag, because cardiologists, they were not afraid to prescribe metformin and CGLT inhibitors. And in this regard, I like the position of cardiologists, because they start from the very low dosage of the CGLT2 inhibitors in the presence of heart failures. But we never had medications that was recommended in order to lower the hazard of mortality. We had some recommended medications to lower the hazard of CVD, but the lowering of mortality, it was for the first time. And it's wonderful. And we can, of course, continue this very long.
Because, I mean, the guidelines from the cardiologists on diabetes were very much advancing the field. And, to be honest, they were off-label use because SGLT2 inhibitors were always tested on top of metformin. So now, if you recommend SGLT2 inhibitors in the cardiovascular risk population without metformin, it is possible, but metformin, if you consider the contraindication like GFR or something, are wonderful drugs. And we have now even more wonderful drugs. You can combine them. Most important thing is get the HbA1c down.
Спасибо, у меня все.
Thank you. That's all from my side. Thank you. I think applauses are for you, for our experts. And in principle, if you allow me, I will also would like to share my opinion regarding the bariatric surgery. You know, the two simple examples. First, when I came to endocrinology, I knew the secret that bariatric patients, after 5, 7, 10, 15 years, they have additional comorbid diseases related to vitamin insufficiency, mineral insufficiency. And professors, they said that it's a teamwork. The psychologists, they prepare. And just a live example, Mr. Bakeri, cardiologist, you know him. He asked me about the condition of our prominent person. I will not talk about the names. And I said he has such problems. And he said the case about in the plane when there was a flight from US. And they had a very simple solution. This patient, he was flying in the first class, 140 kg. And the consultation was $55 and $5 for the medication. And I said, what is this? Professor said he prescribed medication for $5. And he said, every day you close your mouth with this, and this is the best medication for you. And this was the recommendation of a US professor. And if I didn't hear from this Bacteria, this case, I would never believe it, about how doctors in US, they treat patients. And our colleague, he had internship in this hospital in Moscow, Bacteria. He's very prominent cardiologist. And that's the two opinions about bariatric surgery operations. Endocrinologists will not lie. This is very difficult. And experts, they showed that the main thing is the obesity is the main problem. That's the common denominator of everything. And I'm a little bit not agree with the cholesterol issue, but why I ask this question about this German professor? I think he's the main cardiosurgery in Germany. He works in Hanover Medical Clinics. It's university clinics of Hanover City. When he was speaking in the invasive surgery conference, he said that they have data that in atherosclerosis development, the arterium damage plays a more important role, not the small capillary vessels. Said when we, let's say, using microscope, we can see the capillary damages. But we need to zoom out the microscope and look at large arteria. And he proven that the Egyptian mummies, they, the pharaohs, Egyptian pharaohs, and they cooks, they had arteriosclerosis. And he said, before we were afraid we were dying from the not eating enough, but these cooks of Pharaoh were eating a lot. No, they were just sitting, they were cooking all the time. And ordinary people were eating fruits, ordinary products, not processed products. But those cooks of the pharaohs, they were eating processed food. And this is more like a natural food. And he said, yes, I'm not publishing this. I said, I'm sharing this data. Just dig more, do more studies, or confirm or reject my opinion. And so I was listening to Mr. Alexander Borisovich, and I was interested in Damir Sartan and the effect, non-specific factors of inflammation. First, vasa vasorum, arterium has inflammation, there is trauma, and then the other, it will expand to other main arterial vessel, and then this atherosclerosis will develop. Maybe this is the reason that they took off inflammation of the vasa vasorum vessel, and those inhibitor of CGLT2, they actually shown that they take off urine acid, and urine acid they actually result in more inflammation. This is what we need to learn from each conference. We should not just accept the recommendation, but we need to leave conference with a lot of questions that we should answer those questions ourselves in our practice. Such conferences should result in more questions, more debates. Yes, of course, Axel Hiver is not a main expert. Of course, there are data, other publics, and community of cardiologists, but the issue, family doctor, has he right to prescribe CGLT2? And the answer was, if he has experience, if he has confident, if he knows the diagnosis, he has the right, he can do it. And of course, not everyone needs ultrasound echo in order to identify the type of FH. Not everyone needs this ultrasound. And heart failure can be identified with simple. There are many methods. Yes, for example, before doctors were diagnosing with their own experience, and other methods, functional methods, it was additional, let's say, improvement.
Лечение и назначение семейных.
And in this regard, in terms of the prescription of the family doctor and the treatment by the family doctor, he or she can do this. Yes, currently now we are like so-called experts. We are limited. We have limited them all. We have restricted them by the medical standards. Yes, the standard is needed. There is the additional opinion of experts. With standard, 100,000 people are treated. But when the surgeon or the cardiologist or the general practitioner is individualized, then he or she can allow to treat individually. But for this, the baggage of knowledge is needed, because you are making a decision in terms of the health of the patient. And the experts mentioned rightfully, this should be the team approach. Don't take too much on yourselves, personally. You should take advice from the experts, from the specialists. When I make surgeries in my hospital, when I didn't understand something during surgery or during the treatment, I called my colleagues, my friends in Moscow, in Novosibirsk, and in other cities and countries, and I wasn't shy. I wasn't ashamed of asking, of giving questions to them, and I received the great amount of questions, and it was interesting for me to understand this, and this helped us to make our session very interesting. In terms of cholesterol, we had a professor in the Novosibirsk Medical Institute. He was 85 years when he was giving lectures to us. His hobby was to go fishing in winter, and he never said that cholesterol leads to atherosclerosis. He there in 1992 said that cholesterol doesn't play any role here. You will see that later there will be the evidence that the cholesterol is doesn't play a role here. But see how many dementia, how much early dementia we have now in 55, 60, at those who had the anti-cholesterol diet. To tell the truth, me personally, I'm not afraid of cholesterol. Our ancestors, they ate it, they consumed it. But please see how the atherosclerosis of the urban population and the rural population, how they differentiate. The people who live in a rural area, they eat clean products like meat, milk, and fruit and vegetables, but they work at the same time, and they provide the high birth rate. And what we can say about the urban population? Atherosclerosis, high cholesterol. So the pollution of the air, what Hasselheimerich was mentioning, it proves that the climate change, the change of the environment, the air pollution, with which we have the big combat in our country, the green program. It's not only about ecology, about the clean air. This is the fight against CO2. This is the way to prophylactics of the diseases of the lungs, of the cardiovascular diseases. That's why those programs that we see in our state, they are more progressive. They aim at the wider range of issues. If in 20, 30 years we will have a chance to live, like there was a question about 90 years. But in 90 years with 35 BMI, I wouldn't like to lie. The first lecturer mentioned correctly the improve of the life of quality, the quality of life, not just the long years, but the quality of life. Why should you lie just in 90 years being a burden for your children, for your family? In 90 years, it's good to be 90 years, but being active. As cardiosurgeon, me at least, I would like to research the aortic aneurysm in Japan, for example. In Japan, they have the biggest amount of long-living people, and they have the best results. The mortality comes to at least 1%, and we cannot dream even about such a mortality ratio. But they are with atherosclerosis, and the professor was right. It cannot be like the over 80 patient without atherosclerosis. Maybe the genetical resource or the biological age of vessels, it's always different. Once a year, always I look how much hair I have, the peripheral hair coverage on my legs, because there was a conference on cardiologists, and there was a cool lecture about the biological age of vessels, and one of the factors was just to look on the legs of your patient if there is a hair coverage. Of course, if there is no kind of depilation or something like this. If it's a man and there is a good hair cover at the legs, then there is a good communication between the vessels and the hair onion, and those small details should be always kept in mind. And I'm very happy that during such discussion we managed to get into the schedule. But it's very interesting. Always I say thank you when we had the meeting. We should discuss the atherosclerosis problems. We have planned previously time when we had the Cardiometabolic Academy, I will open the secret to you, to cardiologists. In Uzbekistan, we have subclinical deficit of yodum at the population. And then we had this discussion, and then for myself I discovered that's why we have this heart failure at our patients, because we live in such situation when we have problems with yodum, and now me as cardiac surgeon working in those problems, I look there in those problems. When we were conducting this Cardiometabolic Academy, I wanted it to be with cardiologists, but we again made it about cardiometabolism. So this was about the iodine deficiency. I would like to say, again, thank you very much. I just want to finalize, that's why I'm speaking so long. Once again, we thank you, that thanks to such lecturers, thanks to the topic that we have chosen, you see that the audience is still here. I think that they are sitting here not only because of the knowledge or because of the dinner that we're going to have after. They are interested in the knowledge. We had at the previous meetings we had wonderful lectures, and now we have wonderful presentations. And the life shows that those comorbid diseases, they make us kind of have a comorbid gathering of doctors to work together. Our colleagues mentioned that there should be always a teamwork, and this is one of the elements of the success. And in this, I would like to thank you, and I would like to thank our speakers once again for the interesting presentations. I always ask the speakers, can we use your presentations? For example, there was a score 2 or very interesting diagrams. I worked myself on this, for example. This is very interesting. This is a very relevant information. I had an interesting question. Maybe for some of you it's not interesting. What do you use for the identification of obesity? Do you start calculating BMI, or you just use the ribbon, the centimeter ribbon, because there is abdominal obesity? Because some may say to me that I am obese. I'm 95, but I have the muscle core. I came to endocrinology and made densitometry, and they tell me, yes, you have the bigger amount of muscles and bones above fat. That's why come to us and we will help you to identify what do you have, the muscle core or obesity. But for the family doctor, the ribbon is enough. Just the ordinary ribbon you just take and check it. It's very simplistic. We shouldn't make it all complicated. That's why, dear Dr. Professor Dehent, dear Professor Constantino, thank you very much. You're Italian in your origin. So Francesco Cosentino, I'm pronouncing it correctly, I hope. And thank you very much once again. We thank our speakers who, for our country, they demonstrated how clearly we have this information, how much information we can absorb, and how effective our knowledge pool is. We have our own national specifics. We cannot be in some single template, as my colleague mentioned, that we have our own specifics. It's for you, maybe you didn't eat the plov every day, and now we have colleagues from Fergana, they can eat plov every day, they're not afraid of atherosclerosis. I will just use this cholesterol after in another activity. So if you stay here with us for 1 month, you will get into our mentality and into our diet, and then after you can say about your Mediterranean diet and etc. So there are a lot of secret, hidden factors. And how do you keep this Mediterranean diet? Maybe with those with those prices on meat, maybe it's more cost efficient for you to choose fish. Or if you try to stay in Fergana or Andijan, like when we say to people that you cannot take osh, which means plov, and in Kashkadaria we say them that you cannot eat meat, where they eat meat like at breakfast, lunch, and dinner. We cannot forbid this to the people. No, we should look not only to DPP research, and I went further. I looked at DPP-OS research, where they demonstrated, yes, the metformin like in 18-20 years, yes, but the physical exercise, like it stays like it's for 27% improves the quality of life. It stays the same. And what our professor said, you should give up smoking, make your patient be committed to the diet, the active physical exercise, and then only the medications. In 1992, at the university, the great professors, the doctor, the associate professor, her name was Polikova Selivanova. She was studying abroad at that period, and she trained us. At the case when you have the patient with cardiology problems and you start from medications, then as a rule in the private clinics or somewhere else, you may be your license may be rejected, because at all those problems, this is the healthy lifestyle. This is the kind of law that is being postulated every day, like the healthy lifestyle, the prevention of home intoxications, like alcohol, the smoking, and etc. Like, or for example, in Europe, the marijuana was legalized. Again, this is not from the good life. It's easier. It's easier to control people with this. And I hope that we will save our reason. Thank you.
I hope I'm not impolite. First, my presentation is free for everybody. Berlin Chemie has a presentation, and please ask Berlin Chemie, Uzbekistan, and they can always use my presentation. But one thing, I said, without data, one is just a person with an opinion. The good thing is the data are out for the big five, and they never said that they can get 100% of arteriosclerosis and 100% of cardiovascular risk, death. The data are out there that these five big things we discussed are responsible for 60%. And for the mortality, it's 22%. So there's room for lots of ideas. But the data are the data, and the big five we discussed today are proven to be responsible for 60%. And reducing arteriosclerosis by 60% is not bad.
Нам что надо? Фуршет, да? Ну, пожалуйста.
We have a dinner, right? Okay, yeah. Dinner time.
Dear Professor Konstantina, if you would like to tell some greeting words, please.
Has been said. I don't think to add anything else. I thank you for your attention and your patience with us, and it's been really a pleasure to be together this afternoon. Thank you.
Thank you so much. Огромное спасибо всем.
Thank you all, Mr. Khurshid, Mr. Ghairat. Thank you for your team. And you, as always, you invite us endocrinologists for your events.